Good morning and welcome to the channel. Today I'll be discussing knee osteoarthritis or wear and tear arthritis of the knee. If you are in your 40s or 50s and have localized pain in your knee, this video is for you. And I'm Dr. Mahesh Mohan, a board certified physiatrist or non-surgical orthopedics treatment doctor, and I'm also board certified in pain management, and I also worked as orthopedic surgeon for several years. So first we will talk about diagnosing knee osteoarthritis. It's also called wear and tear arthritis of the knee. So we diagnose this knee osteoarthritis from symptoms and signs that we elicit, and also from imaging studies and sometimes blood work. So typically a patient presents with pain very localized to the knee, and there should not be any radiating pain coming from the low back or something like that. And the pain is typically reported on the inside of the knee, because the inside of the knee is the most worn out compartment for most people, or it could be in the front of the knee if it is wear and tear mostly from the kneecap, which is right here. You can see that. So in this model, this is the inside, this is the outside. You can see the fibula on the outside. So most people present with pain either on the inside or in front, and occasionally it could be from the back too. And the pain is typically made worse by weight bearing or walking, or sometimes even the pain is worse in the morning. And typically knee osteoarthritis presents with pain in extremes of range of movements as well. So symptoms are one thing, and then we also examine the patient and elicit some physical signs. We typically request for an X-ray of the knee, which could show some narrowing of the wear and tear area. Like typically the inside of the knee joint may show some degree of thinning of the joint space. We also rule out other things based on the X-ray where we can see the bones. We can also get an MRI. It is asked more and more as we're doing more and more regenerative medicine treatment options. It helps us localize where the pain is coming from. As you know, the cartilage is not where the pain is felt. The pain is felt from the bone itself, or from the ligaments or the menisci. So getting that MRI can help decide where else we should put the biologics when we treat the patient. Next, we will talk about different treatment options for knee osteoarthritis. Typically, people undergo a series of cortisone injections until they get a knee replacement. So that has been the mainstay of this problem for several decades now. There are other treatment options, including physical therapy, which could help if you have a muscle imbalance, like a knee brace or a wedge in the shoe. If there is alignment issues, people take Tylenol for pain all along. This don't really change the course of the disease, but you can get symptomatic relief for a few hours. And very similar with meloxicam or naproxen or ibuprofen. These are all anti-inflammatory medications that help you while you take the medicine for a few hours. And in addition, people also do gel injection, which help you for about 2 to 3 months, sometimes 4. But this has also not changed the progression of the disease. So there are some minor treatment options as we discussed, but the mainstay of treatment stays cortisone injections, which help you for a few weeks, maybe a month or 2, until the wear and tear progresses and you get a knee replacement. And it is a insurance approved treatment, so people do it all along, but having repeated cortisone injections has its own problems. But it's not bad if for a few occasions, especially when it helps in confirming the diagnosis, and earlier on it could help you several months. The difference now, or the main point of this video, is regenerative medicine. Although people have been doing these treatment options, I mean, there has always been mixed reports, and it was, I would say it was probably in its infancy early on. There has been many studies which did show the mixed outcome, and that affects the confidence of the doctors and also the patients in pursuing this treatment. But now with more and more evidence, we have better understanding, and we know exactly where to place it, how to make the better biologic or the PRP or the bone marrow concentrate that we inject. So as of now, there are mainly 2 degrees or 2 levels of treatment. One is the PRP or the blood-based treatment, or the bone marrow concentrate, or which is carving stem cells as well. And they both have different price points, different duration of action. PRP typically lasts for about 15 to 18 months when it works, and bone marrow concentrate lasts anywhere from 5 years to 8 years. So now that leads to a different question. People may be wondering, why would we mess around with these treatments while we could cut the joint away, like a joint replacement? But you should also know that when joint replacement has a shelf life, it's not that once you replace it, it works forever. The replaced joint does not have the capacity to repair itself, and wear and tear happens on the replaced articulating surface itself. So on an average, replaced joints, when you do primary joint replacement, last anywhere from 12 years to 15 years, and then you have to undergo a revision surgery, which is not a great surgery because it works about 75% of the time, whereas the primary joint replacement works about 80 to 85% of the time. And in addition, surgeries are still a major step. It has its own risk, anesthesia, downtime, and time away from work. Whereas regenerative medicine treatment options with either PRP or bone marrow concentrate does not have any downtime, no major risk, no time away from work, and no limitation in what you can do. You would still be kneeling down or doing any extreme sports. Now, going back to the outcome, as we discussed before, there have been many studies with mixed outcome on PRP or bone marrow concentrate injections for that matter. The main difference is that the main point is that there is no homogenization. People do different procedures in the name of PRP. There's difference in what is being injected or the PRP itself. There's difference in the skill set of the person doing the injection, and there's difference in the philosophy. Are you injecting just the joint, or are you also injecting other supportive structures including ligaments and muscles? And most of the high quality studies have injection done under image guidance, like we use fluoroscopy or an ultrasound machine, whereas some of these low quality studies, they did not even have image guidance for injection. And also it depends on where you get the procedure done. Are you getting done by somebody who is specially trained for this or not? And now let's talk about how PRP or bone marrow concentrate injection is done in our setting here in Pain Specialist of Frisco. So definitely we will have a physical examination, a discussion about the potential benefits, risk, alternative treatment options, and also we discuss about where all we are injecting, like are we injecting just the joint, or nowadays we are injecting more and more into the bone also. Especially if there is a bone marrow lesion, we inject into the bone marrow lesion to help heal it. So after this discussion, we bring the patient, we recommend patients to come off any anti-inflammatory medications like Aleve or meloxicam for 1 to 2 weeks before the procedure. And the procedure is a outpatient procedure, but expect to stay about 2.5 hours, as most of our patients do take sedation, and we add nerve blocks to help with injection in a significant percentage of them. Patients typically feel better in about 2 to 6 weeks, and sometimes it can even take up to 3 months. But we are here to support you with other pain management options if in case pain becomes severe enough and that you are not able to stay on non-steroidal anti-inflammatory medications like Aleve. To sum up, now there is a new treatment option which will help many more patients to retain their own knees and stay fully functional with no downtime. Thank you.